Hi, today I'm going to talk about Sbrt, Srt and SRS. So all of these have this term stereotaxy in them. So what is stereotaxy? Stereotaxy is some motion that is happening in space. Like we have 3D CRT, IMRT, which is basically dimensional, 3-dimensional, 2-dimensional. This is something that we are concentrating in the space and targeting a volume. So the features of this is high dose delivery. There is very high dose which is given per fraction, which leads to faster treatment time with decreased number of fractions, and both of this is possible with acceptable toxicity to the normal structures, and there is high accuracy. So through all this there is much better patient comfort and good outcome of the patient. Now, how can this be delivered? There are three ways that it can be delivered. Gamma knife, which is through cobalt, LINAC, which is not, called X knife, that is we are using X-rays as a knife, so that is one, and cyber knife, where we use a robotic arm and which has multiple degrees of freedom to deliver Sbrt. In LINAC we use non-coplanar beam, that is normally when we are doing IMRT or 3D CRT, we use coplanar beams, but here there is another dimension that is explored by using non-coplanar. So these are the three things that we can do. Coming to like radiobiology of Sbrt or SRS, the 4 R's, as we know, are all there, but it acts differently in SRT and Sbrt. Repair is seen in SRT and Sbrt, not in SRS, because SRS is a single fraction. It occurs like since we give a gap of 1 day, alternate days, so there is repair of both the normal tissues and the target tissues. It is beneficial for normal tissues, but is not beneficial for target tissues, but it is combated by all other mechanisms. For example, reoxygenation. So reoxygenation is required because the more oxygen a cell has, the more damage it will be caused by radiation. But in this case, there is more direct damage, and also the size of the target that we are interested in is very small. So very small tumors do not have a necrotic component as much as the other tumors. So oxygenation is not much important in this because of these two reasons. Direct damage, that is it does not require oxygen, and small size, it is not having necrotic component. Then repopulation. Repopulation does not occur only in this because Sbrt, SRT treatments are completed within two weeks. Redistribution, it is so when cells go into different phases, it has different radiosensitivity, but that is all negated because we are using a very high dose per fraction, so that is also not considered. Then there are two advanced radiobiological mechanisms which come into play in Sbrt, that is vascular damage and immune system activation, both of which help in mechanism of Sbrt. So coming to basic differences between 3D and Sbrt, here in 3D there is standard dose per fraction, that is 1.8 to 2 gray, whereas in Sbrt there is higher dose that we deliver per fraction. So it will lead to higher tumor damage. Then margin given in 3D or IMRT is within centimeters, but in Sbrt it is within millimeters. So the accuracy is more, and also the target and OARs that we contour in 3D or IMRT are in general in case of this, but here we contour with higher precision, sharper boundaries. And motion management, requirement of motion management in 3D or IMRT is moderate, may or may not be required, whereas in Sbrt it is very high. Broadly in different areas of the body, like in brain, the indications, the size that is to be targeted is less than 3.5 in case of brain, 4 centimeters in lung, 5 to 7 centimeters abdomen. Abdomen it is higher because here we do not have many critical structures as in brain, but the need of respiratory motion management is higher in abdomen. Now coming to the steps of Sbrt, we have so in the different phases that we execute SBRT in, we have to be careful about the precision. For example, in immobilization, there is intracranial, extracranial immobilization. So we can use either a framed or a frameless immobilization cast. But this is different from 3D CRT or IMRT because this has high reproducibility. And in extracranial, that is outside the head, something called internal motion comes into play. So we can combat this by using abdominal compression, as in liver SBRT, or by using back locks, which tightly fit into the body and do not allow them to move. Now in simulation, so we are using CT simulation of 1.5 mm slices. In 3D it will be 5 mm, in IMRT it is 2.5 mm. So here, since we need more accuracy, we are further reducing it. And there is high importance of motion management, especially in abdominal cases, so which can be delivered through 3 techniques, either dampening, which is abdominal compression, or breath control, which limits the motion of the by ABC or DIBH, and gating and tracking. Tracking is basically chasing the tumor, which is usually done in cyberknife. Next, coming to contouring. So as we know, there is GTV, CTV and PTV, but in SRS there will be only GTV, since we do not want a margin. SBRT, because of motion management, we can include an ITV, that is internal target volume, and a PTV with a margin of 2 to 3 mm. In 3D CRT or IMRT, we will go up to 5 mm. So in SRT, that is fractionated stereotaxy, we use GTV plus a margin again of 2 to 3 mm. This is in the head, but this will be in the body, where we also include ITV. Coming to planning, the coverage that we expect in SRS is at least more than 50%. In SBRT, it is 60 to 85%, which is in contrast to IMRT and 3D CRT, where we expect at least 95 to 100%. Now, one more thing, that the treatment in SBRT is heterogeneous, meaning this is a SBRT treatment. This is the tumor, whereas here the isodose that is reducing is much more conformal as compared to IMRT. This is IMRT. So that means what? Here you have more heterogeneity. That is, this region is a very high dose, this is a very low dose. There is almost no dose here, whereas this is more homogeneous. So you can say that SBRT treatment is more heterogeneous. So thank you.